Welcome back, everybody, to CGM Sweet Talk with the Sugar Queens. I'm Dr. Eden Miller, an osteopathic board-certified family practitioner, diabetologist, and obesity medicine specialist in Bend, Oregon. Today, we're live in Boston for episode 6 of season 2 of Sweet Talk with the Sugar Queens. We are going to talk about CGM and disparities, and we have a very special guest today. Anne, could you introduce yourself?
Yes, hi. I'm Ann Peters. I'm an endocrinologist, a professor of medicine at the University of Southern California in Los Angeles. But importantly, I work in 2 different parts of Los Angeles, one known as Beverly Hills, which everyone's heard of. And I also work in under-resourced East Los Angeles, which people may not have heard of, but it's a primarily Latino, very underserved, medically underserved part of town, and the place I'm most proud of working. So hopefully I can help in this conversation.
Thank you so much for being our guest. Queen Jen.
Hi, I'm Jennifer Goldman. I'm a professor at Massachusetts College of Pharmacy and a clinical pharmacist at Well Life Medical in Peabody, Massachusetts.
Queen Davida.
I'm Davida Kruger. I'm a certified nurse practitioner in the Division of Endocrinology at Henry Ford Health in Detroit, Michigan.
So for the next 25 minutes, we're really going to discuss a variety of disparities related to the use of CGM. So make sure and make this interactive. And if you have any questions, we'll try to get enough time to get to it. Okay, we're going to dive in. We're going to go straight to racial and ethnic disparities. And talk a little bit about what you see, especially since you're equipped at your frontline care, of CGM use when it comes to racial and ethnic differences. Can you talk a little bit about what you're seeing and what the data is about that?
I'll talk about both, but let me talk about what I personally see, because I think this is really important. Is I work in this clinic. It's a primary care clinic. It's a large, like an FQHC, but that's not what they call it. They call it a comprehensive health center. And we have lots of patients, and I have an embedded group of researchers in that clinic, which is really atypical for a clinic like this. And so we do a lot of research out of there in the community with our patients. And my first message is that of complete hope, because by doing that, we've been able to help everybody in that clinic. The primary care doctor, the patients have access to CGM of the care they need and have really improved the standard of care for those people. But it isn't easy to do, and it doesn't happen most places. So in most places, what you see are significant both racial and ethnic differences in the use of technology. And this happens even if you take away the issues of access and even if you take away the issue of cost, because it turns out that different populations seem to have a different perspective on these tools. They need different sources of education. I think they probably need educators who are very similar to them to teach them about how to use them. And it's just been different. And so I think we need to understand that we're, for women non-Hispanic white, we have our own way of thinking. But the one thing I've learned is that my solutions aren't right for somebody else, and particularly not people from communities that are very different from mine. So I think if we can work within these communities and understand communities and what they need, we can do a lot to improve disparities, but you have to really work at it.
I like your perspective of that. It's really kind of even making me think. Davida, why don't you comment a little bit of maybe how you in your clinic setting have been trying to at least maybe top a line, easy to identify or address those?
What it makes me think about is going back to how we relate to the seriousness of type 2 diabetes. And for many, many years, that wasn't a thing. And if you think of some of our communities, diabetes is pretty embedded in their communities, meaning family member to family member to family member. And if this family member has diabetes and they don't take care of it that way, or they don't need the technology, or we don't consider this a serious disease, we consider it a family disease. I think that's part of what I often see is when I'm having conversations, and I think you make a really good point that I may not be able to relate being a white woman in the community. And within our clinic, we try to have as much multicultural as we can. to try and meet that. But I think we have to make sure that all healthcare providers are talking about the seriousness of the disease, options for care. Bring the family members in. Sometimes I find that helps. If you don't come by yourself, we'd like you to see a diabetes educator today. What you hear, we want everyone to hear. Certainly, if that person isn't doing the cooking for the family or the shopping for the family, those people need to be there. But I'm not sure the efforts we're making, the big enough efforts we're making when we know these disparities exist. And the other thing I see is a lot of no-shows. And I don't think we have enough conversations. So I go through the list of the no-shows, and I will tell you probably 90% are people of color. And the questions have to be, why couldn't you make the appointment? Not, you didn't make the appointment. And a lot of times it has to do with no transportation. They had to work. And a lot of things that we don't necessarily take into consideration to even getting them into the clinic to then the next step. But I don't think we make the disease serious enough. And I think that most of their care is done in primary care, and it has to trickle down to them as well.
Yeah. Jen, how do you close that gap in your practice?
I think education is what's most important, and making sure everyone in the practice is sort of on the same page. So everyone has the same message. So certainly of being positive, not judgmental.
Yeah.
What you just said, why did you miss your appointment? But being able to understand what is going on, what can we do? So if you need this technology or you need care, what is it that we can do to help you or help facilitate that for sure? So, conversation, education of the patient, the families, and everyone in the office being able to practice to the top of their license. And as the pharmacist on the group, remember we have pharmacists where I'm embedded in primary care, but there's pharmacists embedded in endo, but we also have pharmacists in hospitals at the discharge point, pharmacists out in the community. It's often the last touch point that people see. So all having that conversation with patients, with the same message.
Yeah.
What can we do?
I liked how you talked about conversations. I'm remembered of an encounter I had a year ago where I was honored to help open the stock, market for the Diabetes Day. And I remember the camper of the year was invited. He was a delightful, cute as a button, 15-year-old African-American. And I ended up sitting by him at breakfast. And, as you know, I have type 1 and he has type 1. And he breaks out a glucometer to poke his finger. And I was just, being a queen,
Wow.
I had to mention, I said, "You're not on a sensor." And he goes, "No." And I said, "How come?" And he said, "It just was never offered to me. I didn't think that I was a candidate." And I'm so glad that when he went to take a shot, it at least was a pen. If he pulled out a vial and a syringe, I think I would have fallen out of my chair. But I remember looking to him and saying, you are the ideal candidate. And please mention to your provider about trying to remove some of the barriers or address them for you.
But I think that to me is what you've just outlined is what I see as being a bigger barrier than patient acceptance. And I think I'm not arguing that that's huge. But if the clinician is not sold, if the clinician doesn't think the patient will use it because they've already have their own preconceived biases, they're not offering it. And we all know that there are biases on the part of the person writing the prescription or offering it. I love that there are now commercials about CGM because hopefully they're on stations that people will see. But I think if we don't go direct to consumer, if we don't have educators, if we don't have ways to reach people so they become their own best advocate, then we're not going to make any headway.
It's like pre-existing barriers that are there. If I can pivot a little bit, I want to talk about, different practice settings, even amongst our group here. I'm in a suburban, small, used to be in rural. Talk to us a little bit about how you see the differences based on populations. Do you think there exists a geographical difference, whether you're in the country or in a big city or an academic institution?
Well, the answer is, of course, there's huge differences. But first, I want to break your rules because you guys seem to break rules. And I want to talk about what comes to mind, which is that I'm the co-chair of this NIH initiative on behavior maintenance. And as part of that, we've interviewed a lot of patients with different chronic diseases, not just diabetes. And the one thing that is the hardest about diseases you wouldn't even think, but in particular about diabetes, is stigma. And wearing a sensor is stigma, and all the sensors are white. And if you have dark skin, it really shows up.
Good point.
And if somebody's wearing a sensor and no other people in the family are, then that person is sicker. And in fact, it's that person's fault.
That's fair.
And so stigma is huge. But the second thing that came across in all these interviews that we did was that what makes the difference is trust in their providers. And so what you're saying, Davida, about providers aren't sold on CGM, I think those of us in this room here are just, to me, it's like it comes out of me. I don't even care.
Hold it in.
Yeah, it's like here, have a CGM. Here, I'll give you some. Oh, see, you have some in my pocket. But it's because I believe so much that I can help people with this technology. And it's a different reality. And I think if you don't have access to people like us, and that's what happens in rural areas, that they don't go to places where there are people who have a lot of experience, I think it's a barrier. And I think the more we can reach out to people, the more it becomes normative. But it's hard, and people don't, we're used to people who don't mind wearing pieces.
Right.
But a lot of people don't want to do that.
So it's interesting that you bring this up because I was at a meeting last weekend. You were actually there too. And the color of the sensor was brought up. And we asked, I didn't, but someone else did, and we all agreed that we have to have choices, maybe not the actual circle, but we want overdressings that match with the skin.
Yeah, I've brought it up a zillion times because it seems so wrong. And all the ads, if you see them, people, it stands out. It's like, hello, I have a light on. It's like, no, let's just cover that, at least make it, I wish we could make it a different color. But regardless, there should be patches or something
There
that
absolutely has to be an overdressing
color
that you can choose.
Just even in our conversations here, we're bringing up different things that are culturally based barriers or opportunities. Like you said, you're talking about hope and opportunities. And, when we look even at population, if you live in a rural community and you only have one provider, you're kind of stuck, right? Like you're hoping that person is going to, represent your needs and wants and desires. And that's, I think, why when I love Davida's concept of everybody, you have diabetes, it's a right, not a privilege. And I think for us is just bringing that awareness to, regardless of which setting you're in, both clinical settings, whether it's private or urban or rural, is that CGM is one of those things that everyone should consider. And even if you don't want to be a CGM expert, find your team and refer, because just in your position, you're a part of that referral base. Maybe I'm the prescriber, but I'm doing that or handing it off to someone else who could be prescribing
A
it.
CGM should be a standard of care. It is standard of care.
It is.
Right.
Our world.
It should be right. It should be for everyone. And I think that what happens sometimes in rural communities, where we are, there's more endocrinologists. So as you move out and out and out, there's even less, and it's really falling on primary care. So primary care has to really, endo can't do everything. Primary care, but we also there's a lot of pharmacist initiatives across the country. And remember, we have virtual now. We can do virtual, and we can look at the sensor data virtually, remotely. So hopefully that will improve access, to rurally, but broadband and all of that also makes a difference.
I don't want to be too righteous either, because I had in the last 6 months 2 incidents with pediatric endos that sent children home on finger sticks.
A lot of learning opportunity. Huh?
They need to watch
And
Sugar Queens episodes.
I
for
actually
sure.
gave both families sensors and said, we'll do a virtual, I'll help you with them, and called both the pediatricians and said, come on.
Yeah.
What did they say?
Well, one said, I don't have a diagnosis yet. I said, well, DKA is a diagnosis. Right?
Hello?
Right. And the other one told me it was Christmas week. And I said,
What better weekend?
Good grief.
I said, well, since you all aren't working, I'll take over and I'll make sure that they're all set up for you. So I do think that we as healthcare providers, given, and there's a lot of us that feel this way, I do think we have to challenge our colleagues.
And we also have to be sure that CGM inertia never gets traced back to you.
Oh, agree.
Yeah. Now let's talk a little bit about inertia related to age.
Yeah, but let me say something. So,
Wait a minute, age?
no. Before I get into that miserable subject, none of us here are aging. But I just want to point out that all these things, it's interesting to me while we talk, because I have these patients who won't wear CGM because you can't turn off the low alarm. And when they're at work, if they're at work and the CGM alarms, they're fired because they're not allowed to make noise, and they're housekeepers and they're whatever they are doing. And so sitting next to you, nothing personal.
Yeah,
but
I went off already.
You've already gone off twice.
Yeah.
And the thing is that you have to be in a world where it's okay
That's fair
to
too.
need to know what your blood sugar is.
But there's a new app with one of the sensors that you can silence all
I know,
alarms.
but that is so wrong. I mean,
I agree.
really think, but I think what I'm trying to say is that the stigma is real.
I see what you're saying.
And that you really have to be in a place, because what if you forget to silence it, where it's comfortable to wear? The world has to be comfortable with this. And so it's not just doctors and pharmacists who are, having issues. I mean, frankly, the diabetes educators I work with are the best because they're the ones who are the least. They're like you. They're like, here, let's put someone, if they have DK, interesting, they should go on a sensor. But those are the kind of people.
Hey, the Queens are just fine with trying to remove stigma of CGM around the world. And you do put a point. You should never be shamed for a CGM alarm.
Any alarm, but you should be necessary.
You should be actually applauded for doing the right thing.
That's what
But
I
I still
said.
got to pivot to age.
Okay.
Let's talk age.
Age. What does age matter? What kind of age are you talking about? I don't know if it's-
Baby queen, that's why she's doing it.
I know, of
Because she's
course.
sitting here.
I mean, I do see it with my colleagues. I've heard it before. I'm out there on the front lines of primary care. That's where I live and work. And sometimes some of my colleagues say, oh, they're too old for it, or they won't understand
course
it.
not.
That's just
We've already done that research and we published it.
exactly.
And we proved that it doesn't have anything to do with age. And I also think because we're doing a better job managing diabetes, people are living longer, therefore they should have the tools they need to continue to live a good, healthy life.
Or what about this? People of advanced age can sometimes have complications related to not managing their blood sugars effectively and have harm. Talk to us about hypoglycemia in the elderly.
Yeah, for sure. I mean, certainly a reason to be offering CGM. Everybody should be offered CGM, period. Hard stop. It doesn't matter how old they are.
Right. And they're all candidates.
Well,
Yes and no, not everybody.
Well, everybody who's
Everybody
should
who's
have
cognitively
CGM.
functional, because I've
Yes.
actually had people who kind of slightly who have cognitive issues, who have issues with CGM. So actually CGM has to be, especially in people who have become somewhat less functional. But I believe it for everybody. But I have people where you can't actually have them see it because they get
They get a little too overwhelmed.
overwhelmed
But a
by it.
family member might want to see
Right,
it.
absolutely.
Or a care person. I had a 96-year-old woman. She was in my practice for a good 35 years. She took care of her own pump and her own sensor till she died. And there's no one that would have been able to take that away from her. And I think some of the fact that she lived on her own till she was probably 90, 92 was because she had these tools and her family member could see her remotely.
Yeah.
Oh, but that's incredible. But those are the great stories. I love those stories.
And I know they're not all, but it really kind of annoys me that someone would think there's an age cutoff
No age cutoff.
versus individual care.
Right.
When someone's ready, yeah.
I am looking forward to Summit going forward because as we age and require different services, many of my clients are going into extended care facilities and nursing homes, and there's a lot of improvement that's needed there. We're starting to see some movement there, but I often see that sometimes they don't know what to do with the CGM when they are put into nursing homes, and I still think there's big opportunities.
There is, definitely for sure. But I think providers have to understand that they shouldn't limit it. It should be offered to someone. Don't assume that because it's technology that somebody who's older isn't going to be able to handle it.
I think in some cases, some of the cases that I think of is I had a 73-year-old female lived all by herself. She was on insulin and she had nothing of support, and that CGM became her support. It became like her family member, she said. She called it her little guard dog who would always be there to help her. So I thought it was beautiful, exactly.
And later we'll talk about you thinking 73 is old.
I did not say, I said advanced age. Now, we know that there exist barriers. We know that there are socioeconomic determiners of barriers. And so what are some of the top of line things that you guys do in your practice to either identify those barriers or overcome it? Those are those pearls that we can give to our listeners to say, hey, listen, these are some of the things that have worked for me.
I think one of the things that comes to mind right off is having those conversations with our colleagues wherever they are, wherever they practice, helping them with prescriptions as possible. And sometimes we have a pharmacy that will help with our PAs, making sure the patients get started. But also, I think it's very important to understand that the way I look at CGM data and the way somebody else looks at it can be different. So that while I might absorb all kinds of stuff that I need for my brain to make a decision, someone else doesn't need all that. And if the healthcare provider is willing to prescribe the CGM, kind of precursively looks at the data and really doesn't want to get engaged in the data, I'm okay with that too.
Yeah.
Because there's enough information that says by just giving a sensor to that person that there'll be an improvement, and that's okay. So I think we have to look at the continuum of care also as we ask people to engage. But I think we have to be more bold in saying, how can I help you so you can turn that corner and you need to be prescribing. We don't see most of the people with type 2 diabetes. That's my primary care colleagues.
For sure. And talk to us a little bit, because you're in more of a unique practice setting where you do already front and center have some of those barriers that are already there, those cultural differences that, and I loved how you talk about the diabetes educators that have a similar background. I'm going to really promote and focus that going forward for my practice.
Well, yes, because my educators are all from the area and they all speak Spanish as a native language and they really relate to the patients. But the way that I've actually changed things is, even though we try to teach the primary care doctors, and I love primary care doctors, don't get me wrong, is that it's obvious a struggle because it's still hard to get the devices. But what we've done is I do studies. And so I've shown the administration in the County of Los Angeles that giving CGM to people with type 2 diabetes improves outcomes. And that's how I get it on the formulary. And so what I've done a lot of is trying to get CGM available on the formulary. Now I'm trying to get people to help the providers get the data so that they can analyze it. But I really push for getting in our state, Medi-Cal, to allow CGM to be available. And I've really worked in advocacy ways, but showing that in my own center, I can improve outcomes by the tool that is CGM has really helped a lot, both in type 1s and type 2s.
Jen, you're in a different practice location than all of us. Tell us about how you are identifying these potential barriers and overcoming them.
I'm definitely asking questions, and what you had brought up earlier is trust is particularly important. So trust with me, with my practice, with my providers there. So making sure that there's that level of trust. And then we have to go out of the way sometimes, which means we might have to do a prior authorization. We might have to pick up the phone and call an insurance company. And so identifying who in your office or wherever you are, who can do that. And if you're lucky enough to be in a situation where maybe someone can be involved in research or involved in where there's accessible CGM. So whether there's a pilot program or whatever that we could refer patients to, but just to make sure that it's offered, period, as a standard. Just it's offered.
Yeah.
Yes.
I think too of also community-based things that we often, maybe I may not be participating in those, but one of the things I like to do is become aware of community-based diabetes improvement, because it's so pervasive in different socio and demographic groups, of getting them involved as well, because we're all on Team Diabetes. I don't know that there is one particular, person that's going to introduce it. I'm fine if we get different, community groups to talk about, how do you level the playing field? How do you promote and advance technology? But I do kind of go back to, I guess I'm representing a bit of primary care, and I often say, we're working on a workflow. So I'm excited about that with the ADA. It's coming out hopefully in the next few weeks. And that workflow is to be, like you had mentioned, it's standard of care. But we're not just talking about something standard of care. We're telling you, almost if imploring you, your life will be better with CGM. Your patients' lives will be better. We all believe that there are certain individuals that struggle with diabetes, certain people that are, how shall I say, have more against them. What if we highlight those individuals for continuous glucose monitoring, because they're going to benefit even more and make them a priority? And so, for me, I've already learned, quite a bit of additional things today that I'm going to take away as well of how to identify it. But I think understanding that there are current deficiencies in socioeconomic and racial disparities. We all believe in CGM. I love the idea of at least color coding a little bit better, get some overlays or something that represents the funness of diabetes if we can make it. And that's why we're having conversations in primary care looking at this, because this is something that is primary. But look at all of us different team members here. We come from very different backgrounds, and we're talking about it. Okay, so we're getting to the end of our program, and we could talk all day, but give us the top of line when it comes to what do you want our listeners to be aware of how we're going to identify them and kind of break through those inertia things that we see, especially in socioeconomic and racial disparities.
I do think it comes down to being able to communicate with people in the ways that they're going to hear your message. And I think that comes from teaching providers as well as patients from all different ethnicities. And it may take a little bit longer for someone to learn who's less comfortable with technology or whatever, but give people the time and care they need and give them the opportunity. And maybe even though it might take a bit longer, they'll end up at the same point if they're given the appropriate support and we give providers the appropriate support.
Oh, I love it. Any final thoughts, Queen? We're coming to the end.
Well, I heard something this week that I think may help us, is that the HEDIS scores want to use GMI.
Mm-hmm.
So if they want to use GMI, that means the primary care providers are going to have to prescribe CGM to get to GMI. Yep. And also, they may be my way to get Epic Aura because they would like it automatically, their reports automatic. So I just sort of laid that. But I'm kind of excited about if we're going to use GMI for HEDIS reports, then that will help the
It's a way to maybe
backdoor.
urge the hand, right?
Yeah.
And
So-
I-
I'm sorry.
no,
I
go
was just going to say that I really appreciate the thought process and going back and looking at, and we're very fortunate we do have multiple options in our clinic. We just need to use them better.
Yeah, I would just say don't make assumptions. That people need to stop making assumptions that whatever population it is, that they wouldn't want CGM or they can't handle CGM, and it should be offered, to everyone. And on the office side, where people think that it might be more time consuming, it's not. It's not more time consuming. It really is such a big asset to the office. You just have to figure out that workflow, which is actually
How about we do this? We want you to change your assumption, and that is CGM for all.
Yes,
Yes,
perfect.
very small thing to say, but not everybody has compatible smartphones. And where I am, only 2/3 of people do and 1/3 don't. So always make sure that whatever we say has the thought that, yes, you can have a reader, and yes, it might not communicate with your clinic. There has to always be that.
Absolutely.
Yes,
And
and
then-
you can plug it in.
And then remember, we got Sugar Queens on that, so you can go back and look at that. Well, again, ladies, we are out of time as always. Anne, thanks so much for joining us.
Thanks
you.
for having
Thank
me.
you.
I love
Thank
you
you.
guys. You guys, you're the best.
We love having you on today talking about this very poignant barrier that we see. But remember, we want you to tune in because we're going to have our Sugar Queens next month, and all of our Sugar Queens are archived. So we're so glad that you've been here with us. Make sure and bookmark season 2. We also are going to have season 3 next year, but we have all of those Sugar Queens archived for you to go back. And we just love having you here, and we look forward to seeing you at upcoming Sugar Queens. So make sure and put it on your calendar and stay tuned in. Thanks for joining us for Sweet Talk with the Sugar Queens.